Snapping scapula syndrome. Robert Whitaker, SPT. University of North Dakota. http://www.thesportsphysiotherapist.com/snapping scapula syndrome scapulothoracic bursitis assessment and management / Overview first described in 1867 by Boyne et 1. Moncler later described 3 subclasses. Frissement, physiologic friction sound. Frotting, loud or grating sound associated with pathological alterations, soft tissue problems. Crackment, pathologic loud snapping sound, loud/painful grating sounds by osseous anomalies. http://ut.b/ctbqg7jp3zw. Snapping scapula, or washboard syndrome 1, painful crepitus of scapulothoracic, ST, articulation, commonly seen in overhead throwing athletes, noises amplified by thoracic cavity such as a resonance chamber of stringed instrument 2. Dyskinesias caused by pain and muscle weakness, imbalances, inflexibility. Crepitus, grinding/snapping noise. Overview continued. Dyskinesia can increase anterior tilt, decrease scapular upward rotation, and increase scapular internal rotation 1. Anteriorly tilted scapula compresses medial border against ribs and scapula pivots around its medial border rather than sliding laterally. Practice pattern 4E, impaired joint mobility, motor function, muscle performance, and ROM associated with localized inflammation 6. ICD-9 CM code, 727.3 Other bursitis. Prognosis, over the course of 2 to 4 months BT. Will demonstrate optimal recovery, 6 to 24 visits. Anatomy. Scapula's role, maintain stable BOS for humerus and dynamic positioning of the glenoid during GH elevation. 2. Clavicle acts as strut for scapula opposing medially directed forces of axioscapular muscles and allowing scapular rotation and translation along thoracic gauge. Muscle tendons and bursa located between thorax and scapula. Several bursa around ST joint to facilitate smooth movement have potential for scapular dysfunction/crepitus. Supraserratus, subscapularis, bursa, between subscapularis, serratus anterior, and axilla 1. Infraserratus, ST, bursa, between serratus anterior, chest wall, and rhomboids 1, facilitates gliding of serratus on chest wall 3. Adventitial bursa, inconsistent findings 2. Superomedial angle, 1 infraserratus and 1 supraserratus. Inferomedial angle, 1 infraserratus. Trapezoid bursa located at base of spine of scapula. Scapula sits 2 from spine located between 2nd 7th ribs, lies 30 to 40 degrees in frontal plane and tip 10 to 20 degrees. Scapulotrapezial, between superomedial scapula and trapezius. Bursa locations 3. Neurovascular anatomy 3. Spinal accessory N. Goes through levator scapula close to superomedial angle and runs along medial border deep to trapezius muscle. Traverse cervical A. Branches anastomose into dorsal scapular A and suprascapular A, superficial branch flows with accessory N. At risk with portal placement cranial to scapular spine or with inadvertent dissection during open approach 3. Suprascapart in and a run towards suprascapular notch. At risk if superomedial scapular resection or superior arthroscopic portal 3. Dorsal scapular A flows with dorsal scapular N 1 cm medial to medial border. Dorsal scapular NA provides innervation to rhomboids and deep to them. Long thoracic nerve located on surface of serratus anterior. Infrequently at risk 3. Neurovascular image 3. Pathology. Crepitus caused by irritation of several bursa around the scapula 2. Chronic, forceful repetitive actions of shoulder mechanisms can induce microtears along periosteum at the medial border of the scapula causing attraction osteophyte at muscular attachment of scapula. 2. Osseous lesion, i.e. osteochondroma, in ST space may become pathologic. Muscle atrophy, disuse/nerve injury, leads to diminished soft tissue interposition between thorax and scapula. Anatomical variance can lead to incongruity. Superomedial and inferiomedial angles can have hook shape, Luschka tubercle. Scoliosis and thoracic kyphosis. Healing fractures of rib/scapula with bony angulation. May not always be pathologic. Snapping may lead to painful symptoms over time. Pathogenesis. Osteochondromas appear to result from aberrant epiphyseal development. They are an extension of normal bone capped by cartilage that forms a prominent tumor, lump, swelling, sometimes referred to as osteocartilaginous exostosis. The younger the individual, the larger is the cartilage cap, because during the growing years, an osteochondroma has its own epiphyseal plate from which it grows. The lesion will usually cease growing when the individual reaches skeletal maturity. The central portion of the lesion is normal medullary bone. The lesion may begin as a displaced fragment of epiphyseal cartilage that penetrates a cortical defect and continues to grow. Luschka tubercle, bony prominence at superomedial angle. Diagnosis: 2 complaints of pain with increasing activity. Scapular noise/crepitus with motion of scapula, single to multiple noises or only palpation. Tenderness at superior angle and medial border of scapula. Pain over levator scapula, trapezius, and/or rhomboids due to contracture and malfunction. 1. History of overuse, sports including swimming, pitching, weight training, gymnastics, and football. Observation of B. Asymmetry in scapula. Handedness may result in slight depression. Winging commonly noted. Moderate to severe forward head and anterior rounded shoulders. PTS able to demonstrate patterns of movement that result in crepitus, observation and palpation, while PT recreates crepitus aids in localizing pathologic scapular segment. Scapular angulation. Superomedial scapula and scapular body normally form an angle that measures between 124 to 162 degrees and may result in focal loading, inflammation, and if angle is sufficient magnitude crepitus. 3, 6% superomedial hooking, 8.6% exhibit superomedial angulation greater than or equal to 35 degrees. Diagnosis: 2SS pain normally not reproducible with isometrics. 1. Flexibility and soft tissue tightness and surrounding muscles, tight back minor contribute to faulty scapular mechanics. Muscle length and strength, upper/lower trapezius, rhomboids, serratus anterior, latissimus dorsi, levator scapula, rotator cuff, and deltoid. Scapulohumeral rhythm, GH elevation ST rotation 2:1. Elevation induces posterior tilting and scapulary R. Faulty patterns include decreased GH motion with increased scapular motion during elevation. Pain normally not reproducible with isometrics. 1. Crepitus easily reproduced with arm movements, pain reproduced generally with shoulder robbed. 1. May be accentuated with compression of superior angle against chest wall. Pain and snapping decrease with crossing the arm lifting scapula from ribcage. 1. Pseudo-winging may be present to compensate for pain with motion. Back minor, elevating resting position of shoulder while supine, tightness will result in affected shoulder maintaining a resting position anterior or higher compared to resting side. Rhomboids and levator scapula best tested placing hands along iliac crest and pressing scapula together by moving elbows posteriorly. Wall push-up for serratus anterior, winging. 3. Lifting arm puts upper trap on slack allowing for further motion. GH first 30 degrees orbit and first 60 degrees flexion 4:1 Tom's notes. Tightness of latissimus dorsi, pectoralis major, and rotator cuff may affect normal motions. Decreased GH motion will lead to protrusion at lateral border of axilla. Diagnosis: 1. Imaging. AP and tangential view. 3D CT to visualize congruity. Fluoroscopy to visualize grating/snapping during shoulder motion. MRI for soft tissue lesion. Selective injections of local anesthetic/steroid for symptomatic bursa, transient relief, inflammation likely present. 3. Differential diagnosis. 2. Cervical spine radicular symptoms, Sperling test for radicular symptoms. C5-C8 can cause symptoms of scapular pain. Quick manual cervical myotome test can help rule out nerve origin pain. GH joint referred pain. Shoulder impingement can alter normal scapulohumeral rhythm, compensates by elevating or protracting scapula to elevate arm more. Leads to overuse of scapular muscles. Electromyogram and nerve conduction time to determine if scapular winging is neurological injury. Other noises? Trigger point referrals, multifidi, trapezius, levator scapula, scalenes, serratus posterior superior, serratus anterior, latissimus dorsi, and rhomboids. Arthritis, labral tear, sublux tendon, AC joint. Conservative management 2. Pain relieving modalities, dithermy, ultrasound, and iontophoresis to undersurface of medial border. Local injections and NSAIDs. If pain persists, PT must be avoided and injections considered 1. Strengthening of weak muscles. Rhomboids, mid/lower trapezius, serratus anterior, teres minor, infraspinatus, posterior deltoid, and longus colli/capitis. Most common lower stabilizers, serratus anterior, mid/lower trapezius. Serratus anterior weakness can cause forward tilting inducing crepitus 1. Focus on subscapularis and serratus anterior if atrophied 3. Scapular at and shoulder shrug strengthen scapular stabilizers, serratus anterior, rhomboids, levator scapular 1. Abduction and elevation of scapula should be avoided from increased pressure and strain on underlying musculature 1. Strengthening inhibited/functionally weakened muscles in both OKC and CKC. Continued conservative 2. Endurance training should be emphasized due to primary function of scapula of static posturing of shoulder girdle. Muscle fatigue can lead to compensatory motion. Many roles of scapula are eccentric. Patterns of movement that include PTs. Required activities. CKC advantageous in early stages because of stabilization effects. Progression from isometric and isotonic to endurance eccentric strengthening. Scaption, press up, rowing, push up plus. Advanced, eccentric scapular control, plyometric exercises such as plyo back, D2P and F, Swiss ball isometric holds. Endurance, low intensity, power output, and high volume, amount of training time from high repetitions of activity, 12 to 20 reps light load, exercises. Push up with plus. IR with cable, conservative management 2. Stretching of tight muscles. Pectoralis major/minor, levator scapula, upper trapezius, latissimus dorsi, subscapularis, SCM, rectus capitis, and scalenes. Weak muscles cannot be optimally strengthened if antagonists not stretched. Postural correction. Thoracic kyphosis, forward head, rounded shoulders, abducted and anterior tilted scapula, suboccipital extension. Will allow for maximum neuromuscular efficiency and improved biomechanics. Reduced kyphosis will improve congruency 3. Use of thoracic spine mobilization to promote correction. Core strengthening, crossroads for energy from low less than, greater than UE. Posture, normal length tension relationship, force couple relationship, arthric kinematics, minimized biomechanical faults, and static proximal stability of shoulder girdle improved. Trunk serves as crossroads for energy transfer, forces can move from lit to UAs or vice versa. Conservative management 2. Lower scapular stabilization can be facilitated with contraction of contralateral gluteus maximus via thoracolumbar fascia. Pain and inflammation should be guided throughout progression. 3 to 6 months conservative treatment failure, surgical options may be considered. PTS. Likely to fail include nerve deficits due to damage, bony incongruities, and those who can snap their scapulas and do so frequently out of habit. Crepitus related to soft tissue, altered posture, winging, or dyskinesia surgery may not be required 1. Operative management 2. PTS. with cervical spine and neurological impairment excluded. Failure to have pain relief after preoperative injection may be contraindicated. Open surgical resection of superomedial angle of scapula, most common for bone incongruity. Supraspinatus, rhomboid, and levator scapula are dissected free and superomedial angle resected with oscillating saw and smoothed with wrongers. Sling and prom begins immediately, aromatid at 8 weeks, resistance at 12 weeks. A wronger is a strongly constructed instrument with a sharp-edged, scoop-shaped tip, used for gouging out bone. Wronger is a French word that means rodent or gnawer. Operative management 2. Bracectomy rather than superomedial angle resection as bone histologically and grossly normal even despite good results. Open procedure. Inferior angle, infisuratus 1. Oblique excision distal to inferior angle. Trapezius and latissimus dorsi split in line with their fibers exposing bursa. Bursa sharply excised and any osteophytes removed. PT at week 1, gittal throwing in athletes at week 6. Superomedial bursa 2. Vertical incision made medial to vertebral border, trapezius dissected free, accessory nerve protect 1, subperiosteal dissection to free levator scapula and rhomboid and preserve tendinous attachments, dorsal scapular 2 cm from medial border protect 1. Bursa resected and bony abnormalities removed, muscles reapproximated with bone drill holes and wound closed in layers with absorbable sutures. Sling for comfort, prom and pendulum exercises immediately, aroma at week 3, strengthening at week 6, gittal throwing at week 12. Accessory nerve along superior scapular edge laterally to superomedial angle and levator scapula 1. Superomedial open resection 3. Immobilized up to 4 weeks in sling. Pendulum and prom exercises immediately. Aroma 8 weeks. Strengthening 12 weeks to parascapular muscles. Operative, arthroscopic 2. Low invasiveness, decrease morbidity and preservation of muscle attachments, early post-op rehab, shorter hospital stay, and higher compliance 1. Painful trapezoid bursa may be missed with arthroscopy. Access and visualization of superior angle of scapula with standard portals, inferior to scapular spine 3 to 4 finger breadths from medial scapular border to avoid dorsal scapular nerve and artery, accessory nerve, and neurovascular structures at superomedial angle of scapula. After portal positioning, arm brought into chicken wing position to proceed with arthroscopy. Operative, arthroscopic 1. PT. Prone/lateral position with arm IR chicken wing. 2 medial portals to view at level of scapular spine, second is working portal located inferior to spine. Upper portal 3 cm medial to spine of scapula through skin to past trapezius, plane between rhomboid major and minor, serratus anterior, caution to avoid pneumothorax or perforate serratus anterior. Inferior portal between scapular spine and inferomedial scapular angle, instruments point away from coracoid process to reduce suprascapular and injury when working in subscapular space. Third superior portal useful when ST bracectomy associated with resection of superomedial angle of scapula. Operative, arthroscopic 1. Third portal, using superomedial angle of scapula and lateral border of acromion as a landmarks. The position is located between the middle and medial thirds of the line joining these 2 points. Anatomical sites of entry must be respected to avoid damage to neurovascular structures and trocar must be passed through as close to ventral surface of scapula as possible to avoid penetration of the thoracic cavity. Inside-out method starting with arthroscope in viewing portal that is directed superiorly from ST space just laterally to the point marked with a needle and exit in the previously marked region corresponding to superior portal. Arthroscope introduced in viewing portal using fluid pressure of 50 to 60 mm of mercury to ST space. Inferior working portal or from superior third portal instruments are introduced to carry out the procedure. Bleeding controlled with radiofrequency device. Fibrous tissues removed with Shaw to find subscapularis, supraserratus, bursa. Superserratus and infraserratus bursa and any fibrous adhesions around removed to expose superomedial angle, resection of superomedial angle if there is a prominence. Careful to avoid suprascapular and damage by directing shower from superior portal to skin target equidistance from spine to inferior angle. Inside out technique, line marked between superior angle of scapula medially and outer aspect of the acromion laterally and divided into thirds, 2 points easily palpable. Point of trocar entry 2 cm medial to medial border of scapula just below the level of the spine of the scapula. Point of exit for trocar is junction of medial and middle thirds of the marked imaginary line, mean distance between arthroscopic superior portal and accessory, dorsal scapular, and suprascapular nerves to be 18.2 mm, 20.2 mm, and 24.6 mm respectively. Flat compared with the rest of the scapula 36 and the arm movement do not determine impingement of this area on the deeper structures. Arthroscopic portals 1. Patient position in lateral decubitus for arthroscopic procedure. Arm in chicken wing position, skin landmarks show the scapula contours and sites, circles, for the 3 arthroscopic portals, superomedial, A, inferiomedial, B, and superior, C, Bell's portal. Operative, arthroscopic 1. Rehab. Passive mobilization first post-op day. Fuller run within 1 to 2 weeks. Strengthening should be allowed after 30 days. PT. Return to sport third post-op month. Other 3. Sling for comfort and discontinued within 1 week. Pendulum and prom exercises immediately. Aroom and strengthening based on tolerance. Conclusion to good to excellent results. Most return to work/sport within 3 to 4 months regardless of operation. Important to adjust proper thoracic posture, scapular control, and strength before return to activity. Questions?